Hello everyone. We will discuss about basic concepts on arrhythmias, so we will discuss in question pattern. 1. What is the relationship between the various phases of the ventricular myocyte action potential and the different ion fluxes across the cell membrane? In phase 0 of the action potential, the sharp rise in membrane voltage is due to sodium influx. Phase 1 involves a brief repolarization that is due to the transient outward flow of potassium that follows sodium channel inactivation. In phase 2, the action potential plateaus are due to a balance between calcium influx and potassium efflux. During phase 3, there is rapid repolarization due to an opposed potassium efflux. Phase 4 is the resting potential, which is maintained predominantly through the opening of potassium channels. Intracellular concentrations of potassium are maintained at high levels in cardiac myocytes because of the action of membrane-bound sodium/potassium ATPase. Opening of potassium channels during phase 4 leads to potassium efflux down its concentration gradient. Since the cell is permeable only to potassium at this time, negatively charged counterions for potassium are unable to diffuse outward with potassium. As potassium leaves the cell, ions left behind cause the cell to become increasingly negative in charge. Therefore, the effluxed potassium ions are attracted back toward the interior of the cell to maintain resting potential. Because phase 4 is dominated by potassium permeability, it therefore has a value close to the potassium reversal potential 85 MV. Note: the antiarrhythmic agents all work by affecting one or more components of the action potential. Class I antiarrhythmics block sodium channels and antagonize phase 0. Class 3 antiarrhythmics work by blocking potassium channels, which prolongs phase 3 depolarization. Some Class IA and all Class 3 antiarrhythmics increase action potential duration as well as the QT interval. Toxicity of these agents can lead to torsades de pointes, which is associated with long QT syndrome. 2. What is the relationship between the various phases of the nodal cell action potential and the ion fluxes across the cell membrane? Nodal cells possess a unique sodium channel, the F sodium channel, which allows them to spontaneously discharge without stimulation. The F sodium channel is open during the resting phase, phase 4, allowing for sodium influx that causes a gradual rise in membrane potential. Eventually, the membrane potential reaches a threshold that triggers influx of calcium through voltage-gated calcium channels. This upstroke is termed phase 0. Nodal cells do not contain a plateau phase. Thus, phase 2 is absent. Phase 3, or the downstroke, involves inactivation of the calcium channels and opening of potassium channels, causing potassium efflux and repolarization of the membrane. Note: the CCBs verapamil and diltiazem, which are non-dihydropyridine CCBs, reduce HOR by antagonizing these slow calcium channels on the SA node. These drugs are considered Class 4 antiarrhythmics. 3. Through what mechanism does sympathetic stimulation increase heart rate? The release of norepinephrine from sympathetic neurons causes activation of beta-1 adrenergic receptors in nodal tissue. These receptors stimulate production of CAMP, resulting in an increase in IF and a positive chronotropic effect on the heart. In essence, sympathetic stimulation increases the cellular influx of sodium ions and decreases the efflux. Note: the beta blockers are considered Class 2 antiarrhythmics. Some medication-related arrhythmias. Drug class IA. Mechanism of action: inhibits Na plus and K plus channels, prolongs QRS complex and QT interval, prolongs effective refractory period ERP. Prototype agents: quinidine, procainamide. Another one. Drug class IB. Mechanism of action: inhibits Na plus channels, shortens repolarization, DQT interval. Prototype agents: lidocaine. Thank you for listening.